Hi guys, my name is Morgan Gott and I did my project on fall prevention. Practicum review. During my clinical rotation at Eastern State Hospital, I spent my hours shadowing an RN BSN nurse in admissions. I was familiar with how things were running on the units, but I was not familiar with how things worked in admissions. I started off my practicum rotation learning about the legal side of things and what criteria must be met for a patient to present and be admitted to the hospital. Patients either present on a citation, petition, court order, or voluntarily. When a patient presents to admissions voluntarily, they are evaluated by a qualified mental health professional, a QMHP. If the QMHP feels like they meet criteria to be admitted to the hospital, then they are sent upstairs to see the physician. If they order on what county they're in, they can either be by QMHP or the court order bypasses them and they're on that. It's interesting to see these other things. I'm familiar with how units are ran, but I was not familiar with the legalities that go on. How a patient is admitted. All that I got to learn how to get hardware paper. We only do electronic medication administration, so admissions is responsible for putting together a chart for the patient, which was interesting to see. Their global assessment and admissions, their skin checks, head to toe assessment, psychosocial, all of the admissions at the admissions center. The physician gets to work with the nurse, and then they do their short little assessment. And the patient, I decided to do my project on fall prevention through identification, fall risk, and early fall prevention interventions and admissions. I got an input post-test and a fact sheet for all admissions staff who participate with increased fall risk for health. Objectives: understand the risk factors for falls, understand how falls can be prevented, assess whether an intervention is effective. Plan: I created a fact sheet for employees to identify risk factors for falls, their knowledge of question pre and post test, implement hospital practices to reduce falls, and after this project, I accomplished by creating a sheet for all staff members in admissions and then administering a 5-question post test after they got the handout. Post test scores on identifying falls risk and falls risk increased after receiving the handout. Admissions also recognized the importance of communicating patient falls and their non-unit and how falls are prevented. There were no false admissions during practicum, no increase or decrease, regardless of early detection. If the orders my project would have to be all employees distributed as a handout. Implementation: these are falls risks at the time of admission. This helps identify certain risks and hopefully early fall prevention before they're transferred to their assigned unit. A fall risk assessment will be performed daily with each fall. If a patient is found to be a falls risk, they will remain a falls risk for the duration of their hospitalization unless the physician decides that they don't need anymore. Once they're falls, they're opened and they receive a red wristband, non-slip red socks, and they get a leaf already at the door. Admissions room shut off. A safe unit environment is maintained. No water, no clutter. The staff will enter the falls. Age, mobility, peaceful gait, visual impairment, lighting, where environmental and locations are also falls in that domain. Pre-test and post-test who was involved with direct care got administered this fall risk questions. This actually the form that I had them do. It was short, 5 questions. The average pre-test score was 88.5. The average test score was 97, which increased. Only 7 weeks completed a lot of shifts that my pre-4 to end up kind of working with people. So I could totally implement this in my work right now onto the unit. This is executive is all essential is like all our each patient test citation, notify documentation call, and then this is the fall protocol. that has to be initiated. The red leaf, red sock, shower turned off, red wristband, white. And this is the false scene investigation report. It's hard to see much, but the shift coordinator has to fill one of these out on every vehicle. All that together there. So this is proposed today. Was it the environmentability? Was it the whole report? And it's all which is all what we learned in the literature. My professor and I, we classification, related information to all respective parties. When a patient is admitted to the hospital, the nurse initial assessment, and after the nurse gathers the information they need, they give the physician a summary of their assessment before the physician goes and sees the patient. So we use the SR technique all the time. Situation, background, and recommendation. The admission would be this information to the physician and the patient to the unit. So I really got familiar with SBAR. Any patients to gives brief summary of why the patient is being admitted. Then background information, have they had multiple admissions, key assessment findings, what level is on, and then what the provider will be. In the literature, we also learn about patient safety, quality care, high reliability organizations, communication. And this organization has a very effective reporting system that shares key information from one shift to another. I know a little bit of everything from the literature and practical experience. Best practices, focusing on focusing risk factors for falling, and then implementing the interventions. Eastern states to par with the best practice. Risk factors, older adults, gait and balance, medication issues, visual impairment, environmental hazards. All of these best practice fall prevention interventions are being utilized. Reflection and overall, I'm a preceptor, did a phenomenal job at helping me get information on hospital, showed me about clinicians. Our views about interprofessional teamwork skills and communication really helped me notice how well the team works together to admit patients and get them in the unit. I really learned that with the interprofessional teamwork, that if the nurse and physician didn't work well together, the patients would really compare them on units. Mostly the nurses and HAs are just not the main ones that are in charge of physician and writing a couple words and really mainlining their medication. But admissions and nurse and physician really work together along the way in order for it to be admitted, seen, assessed, and transmitted to the on. It was really cool to see how everyone was that you went to admission, you probably put out one that light one had on who was our PHA or the physician. They work that well together.